think everyone will have to unmute again and consent to being recorded. Sorry about that.
That is okay. Thank you, Patty. All right. Welcome, everyone. Welcome to Lake County's Behavioral Health Services Act Community Planning Meeting number 3 for the fiscal year 2026-29 Integrated Plan. And before we get started, I'm actually going to kick it over to Elise to welcome us into the space and to kick us off. So Elise, please go ahead.
Hi, everybody. It's great to see you. I actually was going to try to be incognito, but that I'm not sophisticated enough to pull that off. So I am in my pajamas because I am actually out sick today, but I couldn't not participate, or rather couldn't not hear what the community has to say. There's a lot happening in the BHSA. But what I can tell you is that myself, in partnership with our entire leadership team, as well as in partnership with our state advocates, have worked really hard to try to figure things out. And obviously RDA as a consultant helping us figure out the new BHSA process and what the shape of the future looks like. And so in saying that, the shape is changing, and that's something that we're going to talk about. I know change is hard, and I think that we're all pretty probably beaten down by a lot of change at this point. Or maybe I'll just speak for myself. It's been a journey since Prop 1 and behavioral health transformation and CalAIM. And so as I have told my staff quite often, like, hang on, it's a wild ride. The ride continues. And so to those of you that continue just like buckling up and hanging in there, I really appreciate you. To the community that continues to show up and be so deeply invested in this process and in protecting our most vulnerable people. I have a lot of love for you all. So that's it. Thank you.
Thank you, Elise. Thank you for joining us despite you being sick. Feel free to stay off camera. And I want to echo that. Thank you all for being here and giving us your time today. All right, so we have a lot of folks joining us today, so it is a little bit difficult to do individual introductions as much as we would love to. So if you're able, we ask that folks put their name, their pronouns, and their program, if you are affiliated with a program, in the chat. And I want to quickly introduce our team. So my name is Paulina Hatfield, and I'm a senior consultant with RDA Consulting. My colleagues, Jamie Dorsey and Julia Owens, are also in attendance, and we're working with Lake County Behavioral Health on their BHSA integrated plan for the next 3 years. We've been working with Lake County Behavioral Health for the past couple of years. We assisted with last year's annual update, as well as the last 3-year plan for 2023 through 2026. I do want to acknowledge that this is a hybrid meeting, and the peer support centers have graciously agreed to host the meeting in person. And so I just wanted to take a moment. If the peer support centers are able, feel free to come off mute and say hello. We would love to know how many folks are in the room and give you a moment to say hello. So would anyone like to kick us off? I know Davey is there for Big Oak. I think also Carrie.
We have the harbor here. So, hey, and Gara, hi, it's my hand there. We have Harbor and Nest present. Hello.
Hello.
Amazing. 9 of us.
Awesome. Thank you all for coming. Thank you so much. Are there any other peer support centers that would like to come off mute? You can also throw that in the chat.
Sorry, I was dealing with my new best friend. So Carrie Manning here at the Circle of Native Minds, and we have about 10 people here this morning.
That's wonderful.
Yeah.
Thank you all for being here. Thank you, Carrie. Good to see you.
Good to see you too.
Awesome.
When you work for Clay Oaks, David Abel.
8 people.
8 of us.
8 people. Awesome.
People from the Big Oak Center.
Great. Thank you so much. Thank you all for being here. All right. Are there any other peer support centers on the call? Oh, I see Edgar at Lavos. Are you able to come off mute?
Can you hear me? Hi, everyone.
Hello.
Hello.
Awesome. Okay. I think we'll get started then. Thank you so much. It's always so good to see people in person, and I really appreciate everyone making traveling to the centers and being there. All right. So why are we here today? So today is the third community program planning meeting for Lake County Behavioral Health's BHSA 3-year integrated plan. We've had 2 other meetings before this, and I see a lot of familiar faces and names. So thank you for coming to our third meeting. For a little bit of background, the Behavioral Health Services Act replaces the Mental Health Services Act, which used to fund behavioral health programs in Lake County. BHSA changes how funding can be used, and Lake County Behavioral Health is working to shift programs and services in a way that meets community needs. And today is one of many opportunities for the community to come together to learn about BHSA and provide input. So our objectives today. We want to provide an overview of BHSA. I know many of you have been a part of these meetings, and we always do an overview, but it's always good to have a refresher. And for anyone who's new today, to also learn about BHSA. We're also going to provide opportunity for everyone, community members, to review and discuss findings from our community needs assessment. And we're going to all have a discussion together to identify potential opportunities and program changes to better address community needs. So these are some quick tips on how to fully engage in today's meeting, with this being a hybrid meeting. So for those in person, there's a coordinator on site to manage the meeting. And for those joining virtually, we ask that you find a quiet, distraction-free location with a strong internet connection, but I know that's not always the case or always possible. So please let us know in the chat, and one of my colleagues will try to assist you with any technology needs. We also ask that you please save any substantial comments, questions, or feedback for the Q&A portions of the meeting. We're going to have those throughout. And we have a large group discussion at the end of the meeting as well. But of course, if you have any clarifying questions, please feel free to throw them in the chat or raise your hand. And if you're in person and have a question, feel free to physically raise your hand, and your on-site coordinator will let us know that there's a question. All right, to finish us off, here are some tips on how to contribute to the discussion. For those online, you can raise your hand by selecting the raise icon at the top of the screen and press the mic icon when you're ready to speak. If you're calling in via phone, you can actually raise your hand by pressing *5, and you can unmute yourself by pressing *6. And also for those online, you can use the chat below. You can click on the chat icon at the top of your screen and type your comment into the chat box. If you have any comments that you don't want to share in the meeting, you can send them to Scott Abbott via email, and his email is on the screen. All right. We're going to do a quick poll. We've done this type of poll in the past. It's called Mentimeter. You can scan the QR code on the screen, or you can click the link in our chat. It'll take you to the poll. You can do it on your computer, on your phone, on your iPad. And we would love to know, have you been to a previous Lake County Behavioral Health MHSA community meeting in the past? We've done these for many years, and I know there's a lot of familiar faces. So we'd love to know if you're returning, if this is your first time. Yeah, so I'll give everyone a moment to scan the QR code or click the link in the chat.
Pauline, are you sharing your screen?
Oh.
You know what? It probably booted you out of sharing when I hit record. So you probably got to just reshare that. Sorry.
Oh my gosh, have I not been sharing? I'm so sorry.
It was there, and then I hit record, and it booted you right out of there.
Oh, goodness. Well, I'm sorry about that. Okay, let me share my screen one more time. And actually, we might just skip the poll for the sake of time, and we might actually just go right into a video that we have for everyone to watch. All right, are you, actually, hold on, let me reshare my screen. We're gonna get it right this time. Okay, so I'm gonna be playing a video. I really quickly have to turn my audio off so that I could share this audio, so one moment.
Behavioral health conditions
Is everyone able to hear that okay?
Yeah, you're good.
include substance
Yes.
use disorders and mental illnesses. These conditions are often the result of both genetic and environmental factors. And just like cancer or arthritis, they deserve the same compassion and urgency in treatment. Yet, people living with behavioral health conditions face stigma, blame, and fear. Too often, they struggle to access the care they need. That's why California has a safety net, built through a partnership between counties and the Department of Healthcare Services, coordinating across many different systems. At the center of the safety net is County Behavioral Health, which is an insurance plan, a service provider, and a part of county government all at once, delivering critical care to people in need, helping them find stability and improve their well-being. Every year, hundreds of thousands of Californians receive services through County Behavioral Health. They're people who are on Medi-Cal and living in poverty. They may have lost their homes, jobs, or family connections. Some may be in the care of other government systems, like child welfare services, while others may be re-entering the community after incarceration. They're adults and children of all ages. For substance use treatment services, any individual with a diagnosed disorder related to alcohol or drug use is eligible for treatment. These are people living with a chronic relapsing disease that is treatable. For mental health services, individuals must meet certain criteria. Their condition, whether diagnosed or suspected, must significantly impair their ability to work, maintain housing, care for themselves, or function in school. These are children and adults living with serious conditions such as schizophrenia, bipolar disorder, major depression, and PTSD. At its core, County Behavioral Health is a specialty system tailored for those with the most serious needs. Most people think of behavioral health care as therapy and medication. County Behavioral Health does that, but they also offer something far more expansive and urgent. County Behavioral Health works with people who are in crisis, with complex needs and situations that don't fit neatly into an appointment slot. Care begins wherever a person is, in a clinic, in a shelter, or on a street corner. For substance use disorder, care begins with helping people through the physical crisis of withdrawal, often with medication. From there, the longer journey of recovery begins. Residential programs, outpatient counseling that works around jobs and family, and peer support from people who've walked the same path. That connection often becomes the turning point. For mental health needs, counties provide therapy and counseling, but also ongoing support that helps people navigate daily life. For adults, this might mean managing a household again, reconnecting with family, or returning to work. For young people, it's about building skills to succeed in school, at home, and in their communities. It's about rebuilding a foundation, one step at a time. County Behavioral Health also meets needs that go far beyond traditional treatment. Outreach for people who are unhoused, help accessing food and benefits, support re-entering the community after incarceration, and pathways to job training or schooling, as well as prevention and early intervention services to stop these diseases before they become severe. County Behavioral Health treats the whole person, knowing that healing takes time, trust, and persistence. Like much of the healthcare sector, County behavioral health systems face significant workforce challenges. Yet, even amid shortages, the professionals who staff the system are deeply committed to the communities they serve. Across every county, counselors, social workers, psychologists, psychiatrists, nurses, case managers, and peer support specialists provide essential care and guidance. Their clinical expertise, lived experience, and cultural understanding form the backbone of California's behavioral health safety net. County Behavioral Health is actively working to recruit, retain, and support these professionals through training programs, loan repayment initiatives, and pathways for peers with lived experience to become certified providers, building the workforce that makes recovery possible. To understand how this system works, you need to understand how funding flows through Medi-Cal and the Department of Healthcare Services to support county behavioral health. Three sources provide nearly 80% of all funding for county behavioral health. First, Medi-Cal, the single largest source. It's California's Medicaid program, funded by both the federal and state governments. When counties provide behavioral health treatment to Medi-Cal beneficiaries, the federal government pays roughly half the cost through what's called federal financial participation. This is why Medi-Cal is so powerful. County funds can be matched by federal funds. Second, a 1% state tax on personal incomes over $1 million, called the Behavioral Health Services Act, or BHSA for short. Third, realignment funds from state sales taxes and vehicle fees distributed to counties. The other 20% comes from a variety of state and federal funding sources, including annual general fund support from the state. County behavioral health braids these different funding sources together. This is Alex, who's living unsheltered with untreated bipolar disorder. A peer outreach worker, paid through Medi-Cal and realignment funds, connects with him on the street. Funds from the BHSA help secure him a room in supportive housing. Once stable, he starts therapy sessions billed to Medi-Cal, with the county using realignment dollars to unlock the federal match. One person's recovery required multiple funding streams, each activated at different moments. Each funding source comes with its own eligibility rules, claiming processes, and reporting requirements. But those receiving services don't have to worry. It's the trained service providers that navigate the funding system to ensure services are provided effectively. There are other complexities too. Typical health insurance, like the plans people get through their employer, receive a set amount of money per enrolled member per month, regardless of service use. This predictable revenue allows plans to budget and manage financial risk. County behavioral health plans don't work that way. They must use tax-based local revenue to pay roughly half the cost of services. Only after those services are delivered to eligible Medi-Cal beneficiaries and successfully claimed through the state can counties draw down federal matching dollars. When the local economy slows and tax revenue drops, county behavioral health has fewer dollars to provide services, exactly when demand typically rises. When tax revenue increases, county behavioral health has more dollars to spend. Additionally, federal reimbursement rates vary based on who received care. County behavioral health plans both provide services directly and by contracting with providers in the community, such as nonprofit transitional housing or recovery organizations. This means counties must manage costs by running efficient clinics and negotiating contracts in a high-demand market with limited specialized providers. County behavioral health stretches to fill the gaps left by the broader healthcare system, serving not only people who are ineligible for Medi-Cal, but also those who are uninsured or underinsured, often using local funds with no federal match. Amid all these complex demands, county behavioral health continues to adapt their services and is always working to respond to changing community needs through community engagement, workforce development, and careful planning to ensure people can access services when and how they need them. Whether someone calls for help during a family member's crisis, checks themselves into a facility for treatment, or is approached by an outreach team while living on the street, they can expect to receive the quality care they deserve. and the support needed to regain stability with dignity. Together, across California, County Behavioral Health meets people where they are and maintains its dedication to doing whatever it takes to strengthen the safety net, improving access, support, and outcomes for the people who need it most.
Right. Can everyone hear me okay? I think I just switched over. Perfect. All right. Thank you all for watching that with us. So we wanted to kick off the meeting with that video because it really does a good job of explaining the work being done every day by County Behavioral Health. It really tells the story of who's served, how they're served, and the commitment of the behavioral health workforce, and also covers BHSA and a lot of the complex funding that's at play in delivering these services. The link to the video will be dropped in the chat if you'd like to view the video again later, or if you'd like to share it with someone else as well. All right, so next up, we're going to be going into an overview of BHSA. So today we're going to be going over a lot of content. And so to hopefully help, if you have to reference something again or want to go back a slide, I'm going to have one of my colleagues drop a link to the Lake County Behavioral Health webpage. And the slides are posted there in both English and Spanish. So if you'd like to download those and have those and follow along, I highly encourage that. Okay, so before we can talk about BHSA, we first have to go over what MHSA was. So the Mental Health Services Act was originally Proposition 2063, which was passed on November 2nd, 2004. It's a 1% tax on income over $1 million to expand and transform mental health services, commonly referred to as the millionaire tax. MHSA was the predominant funding source for many counties. MHSA funds Lake County Behavioral Health mental health programs under 5 component areas, which is the table to the right. These are probably very familiar if you've been to our meetings in the past. So the Mental Health Services Act is now being transformed into the Behavioral Health Services Act as a part of Prop 1. This slide serves as a reminder of the programs that are currently funded by the Mental Health Services Act in Lake County through fiscal year 25-26. I'm not going to go through all of them, but you'll see a lot of familiar names from crisis to the full service partnership programs, mental health first aid, as well as workforce education and training initiatives that Lake County is currently carrying out. So here's a brief overview of Prop 1. So Prop 1 was an initiative proposed by Governor Newsom to modify the behavioral health system, emphasizing the expansion of housing and treatment options for those with serious mental illness. Prop 1 was passed in March of 2024, and some of those key priorities include focusing on the most vulnerable individuals living with serious mental illness and/or substance use disorders and are at risk of homelessness, unhoused, and/or justice involvement. Increasing access to permanent supportive housing, increasing access to substance use disorder treatment and co-occurring services, creating transparency and behavioral health planning, fiscal expenditures, and client outcomes. So those are some of those key pieces of Prop 1, and full implementation is actually expected by July 1st, 2026, but really began in 2025. Prop 1 had 2 components, or has 2 components. First, a Behavioral Health Infrastructure Bond Act authorizing about $6 billion to build or develop behavioral health housing and treatment. And then there's the Behavioral Health Services Act, which is what we're focusing on today, and that amends the Mental Health Services Act. So some of the key changes include renaming from MHSA to BHSA, expanding services to include substance use treatment, revising the distribution of MHSA funding to prioritize housing, emphasizing full service partnerships and evidence-based practices, shifting funding for prevention programs from the local level to the state level, mandating an integrated plan for department-wide behavioral health services, not just those funded by BHSA. It establishes statewide population behavioral health goals to inform county planning and resource allocation, and also requires collaboration input from a much broader group of community partners than was required by the Mental Health Services Act. So as mentioned before, the switch to BHSA revises the distribution of MHSA funding to prioritize housing. And this changes the original 5 categories under Mental Health Services Act to 3 under BHSA, which includes full service partnerships, behavioral health services and supports, and housing. As a reminder, full service partnership services include comprehensive and intensive care for people at any age with the most complex needs. Behavioral health services and supports, or BHSS, includes early intervention, outreach and engagement, workforce, education and training, capital facilities, and innovative pilots and projects. And housing, which is a new funding category, includes behavioral health housing that increases access to permanent supportive housing for people meeting BHSA eligibility. So in order to develop the integrated plan and understand how funds should be used at the local level, the Behavioral Health Services Act intends that there be meaningful community engagement and a meaningful community planning process, which is what you all are engaging in today. You all, the community, are the subject matter experts of your local behavioral health needs, the strengths, the gaps, and Lake County Behavioral Health wants your voice heard in this process. And most importantly, we hope that all community members of different backgrounds, experiences, and perspectives join our meetings and our efforts. Under BHSA, counties are required to engage a really broad range of partners, including the list that I have here on the screen. We want to hear from participants, folks that are receiving behavioral health services and their family members. We want to hear from providers and staff. We want to hear from partners in the healthcare, education, public safety, social services sectors. We want to hear from housing providers, veteran services providers, local government and tribal representation, as well as labor representative organizations or unions. So we want to hear from trying our hardest to outreach to as many people as we can to be involved in our meetings and our surveys and our focus groups. And lastly, everyone has a role to play in this community planning process. And here's a snapshot of everyone's roles and responsibilities. So community members are integral in bringing their individual perspectives and lived experiences when reflecting on needs and prioritizing strategies. Lake County Behavioral Health is responsible for developing the integrated plan. The Behavioral Health Advisory Board assures that there's community involvement in this process. They also review and approve the integrated plan and conduct the public hearing. The Board of Supervisors also reviews and approves the plan, and RDA Consulting supports the community planning process. We facilitate discussions, and we're supporting Lake County Behavioral Health in developing their plan. Lastly, here's a breakdown of all of the BHSA planning activities that have happened and are to come. So I'm going to focus on the green portion, kind of in the middle. So right now we're having our 3rd community meeting. And next up, we are going to be drafting the integrated plan and submitting the draft plan to the state by March 31st, 2026. So next month. Next, we're going to have a public comment period where it's going to, the plan is going to be available to everyone publicly. You're able to review the plan and submit comments. So that is actually coming up in the next month. And that public comment period is going to end with a public hearing hosted by the Behavioral Health Advisory Board. We're going to update the plan with state and public comment feedback. And then once we finalize the integrated plan, we're going to present it to the Board of Supervisors, and we will submit the final plan by June 2026. So that is all that's to come. And there's a lot to do. So Lake County Behavioral Health has been hard at work. All right, if you'd like to learn more about BHSA, please visit Lake County Behavioral Health's BHSA webpage, and that link will be dropped in the chat as well. In addition, if you're able to download these slides, we have an entire slide dedicated to additional BHSA resources. So if you have time later on and you're curious and have questions, we linked a lot of really great resources that will hopefully help bring clarity to any questions that you have. But for now, we do want to open it up. Does anyone have any questions around BHSA that they'd like to share right now that we can answer? I'm just going to open it up for a couple of moments. So feel free to come off mute to share your questions. You can type them in the chat, or if you'd prefer, you can send any questions, comments to Scott Abbott via email as well. But I will stop talking. Does anyone have any questions?
Does everyone feel like they have a pretty good grasp on the transformation from MHSA to BHSA? Any questions about that?
Nobody else putting questions in. Can I introduce one?
Please.
So, would you like to comment on the role that BHSA and Behavioral Health Services in particular is going to play as we roll out medication assisted treatment or medically addiction treatment for the jail? I'm
Yes,
thinking
I'm happy to address
specifically of
that.
what happens after post-release.
I'm happy to address that. So BHSA is a separate specific program from CalAIM. CalAIM is an administrative initiative that I refer to as a constellation of different initiatives to advance and innovate Medi-Cal or Medicaid. And so within the CalAIM constellation, there's already been reform through the Path Cited, the Path JI initiatives to advance these type of reforms, including for the first time ever coverage of inmates who are within 90 days of release who are eligible for Medi-Cal. That and as well as medically assisted treatment and all of the services that occur within the jail, the BHSA does not touch that. The BHSA will touch people the moment that they step foot out of the jail. So it's important to note also that BHSA funds and services can only be used for voluntary treatment. And if you're in jail, that's just not, it doesn't work statutorily. So when people touch foot outside of the jail, justice involved teams such as assertive community treatment or forensic assertive community treatment are now eligible bundled service packages within behavioral health transformation. But it's important to bifurcate that Proposition 1 was a lot of things. It was a bond. It was also a massive reform into accountability for behavioral health plans. And it was a restructuring of how BHSA funds are allocated. Does that answer the question?
Yeah, thanks. I tried to focus on post-release, and I appreciate your pointing out that distinction. And thanks so much for the way in which you and April and others have been working with us as we plan for the implementation of MAT in the jail and on post-release services.
I'd like to add a little bit to Elise, if you don't mind. BHSA is part of behavioral health transformation, which is a bigger topic than BHSA. But BHSA Proposition 1 also required that we formulate what's called an integrated plan. Previous MHSA plans had focused just on MHSA programs. BHSA is now requiring an integrated plan which covers our entire department. So although BHSA funds, as Lisa described, may not be used for jail services, that will be part of the integrated plan, because we will be addressing all that we do within that plan.
Yeah, thanks very much for adding that comment, Scott, and information, Scott. We participated in a review of experience in Sutter, Yuba counties, and we'll be participating in a review of Sacramento County's experience with post-release services, and hopefully be able to use those experiences as we implement our own services here in Lake County. So thanks for adding that comment.
You bet.
Thank you.
Thanks for your question. Any other questions?
There was one in the chat, but Elise answered it. Kimberly Guerra asked, the Harbor and Nest are curious if it has been determined whether BHSA restructuring will impact funding for peer support centers and housing programs like the Nest. And Elise answered yes, and that will be discussed today after our break at the hour. So after 11, we'll be diving into that.
Right. We definitely want to be covering that. I think one of the, our next phase that we'll be doing is talking about the community needs assessment. And that's what it's okay if I introduce that a little bit, Paulina. Community needs assessment is a presentation that RDA will be doing of all the data that they've collected from us, all of us, the community, concerning what behavioral health should be doing, what we are doing, and what all the many questions, the surveys that we've done, and to kind of present an idea of where the community from these reports are at as far as kind of what we should be doing, and then from that data and what has been expressed, hopefully that will lead to us formulating a plan of what we can do. And of course, as all plans are, and I'm going to say this probably a couple of times today, is we are restricted by just the resources that we have, the capacity of the funding that we receive, and so we'll spend some more time talking about that later.
Thank you, Scott. I think that's a really good segue into the needs assessment findings. So I'm actually going to pass it over to Jamie to kick us off in this section, and then we'll go from there.
Thank you. So this next section is going to be the key findings from the community needs assessment. And before we move on to the next slide, just so the information that we're sharing is from a community survey that we launched. Actually, you can go to the next slide, Paulina. So this is kind of all of the information that we've taken from the community program planning activities. So far that has been the first community meeting, which was in October, and we had 46 folks attend, and that included some discussion. So the key findings from that discussion are included a community survey that was launched in November that was open until the beginning of January. We had 70 folks participate in that. So we'll share the quantitative data findings from that. And also there were some open-ended questions that are going to go into like the qualitative key findings that Pauline is going to walk us through. We had the second community meeting in December where we had 60 folks participate, and we also had a lot of discussion in that meeting. So those, the key findings from those discussions will be included in this needs assessment. And then our team, as well as some folks from Lake County, helped facilitate a number of focus groups and interviews between mid-November until mid-January. And in total, we had 76 folks participate in that. So all of those findings and conversations are also kind of feeding into this needs assessment. So in total, we've had 252 people participate so far, which is amazing. That is a duplicated number because we do have a lot of people that kind of participate in multiple events, but still just really great turnout and a lot of voices that we're hearing. For in the community meetings and for the community survey, we do distribute the demographic survey, and that information helps us understand who's participating. So from those activities, we had 176 folks, and this graph on the right kind of shows the breakdown of the types of folks that were participating. So about a third were behavioral health services providers and staff at those organizations. About a quarter were folks who are participating in behavioral health services or their family members or loved ones. About 20% were housing and homeless services providers and medical or healthcare providers. And then about 20% were folks who identified as kind of a different community group. And that includes social services, education, local government, tribal representation, public safety partners, and other community members. We did have for about 25% of folks, we don't have kind of the community affiliation. So just another plug to fill out the demographic survey, because it really does help us understand who's participating and whose voices we're hearing and whose voices we're not hearing. So it's really important for us. So just a little plug there. And on the next slide, so this is just an overview of who we talked to in the focus groups and interviews. So we didn't have demographic surveys for this group. So just wanted to provide kind of an overview of who we talked with. So there was a focus group with LCBHS providers. We also talked to external or contracted providers from housing, from education, from other kind of community-based behavioral health providers. We talked with the managed care plan in Lake County. We talked with folks at the Circle of Native Minds, at the Harbor, at Big Oak, at Lavos. There was also a group that the parent partner led with families, and then also a group with older adults. So in total, 76 folks participated in those interviews and focus groups. And so there's a lot of information on this slide, and I know it can be a little bit overwhelming, but so in the community survey, for anyone who took it, maybe you're familiar, but there were 13 questions that are what we call Likert scale questions that kind of ask you to rate how true a statement is. So all of those statements are here on the left. And in this graph, we have folks who felt like the statement was very or mostly true. Those are kind of the green bars. For folks who felt like the statement was only a little bit true or not at all true, we have the yellow bars. And then in the gray, we have folks that said that they didn't know or they didn't feel like it was applicable to them. So in this kind of first grouping, the first kind of group of questions or statements was around service needs. And overall, kind of the key findings from this were that perceptions were a little bit mixed. So in this very first row, we see that over half felt that peer support services really are meeting the needs of the populations that they serve. And in this last bar at the bottom, we're seeing that only about 30% felt that intervention services help people before mental illness or substance use disorders become debilitating. So having really positive kind of feedback about the peer support services and maybe a little less positive about early intervention services. And then in the middle, we have about 46% of folks felt that the services provided by LCBHS are meeting the community needs overall and for people experiencing a behavioral health crisis. And about 40% felt that services identifying care for people with untreated behavioral health conditions, and about 40% felt like that was only a little bit or not at all true. So a little bit of kind of mixed findings on meeting the service needs. In this next group, we have the LCBHS findings about accessing services. And what we see in this very first bar, we see, or in this first line, we see that about 70% of folks said that they know where to go or call or who to call if they need behavioral health support. But then we're also seeing that a lot of folks are only about 37% of folks are saying that behavioral health appointments were available when they needed them. So it seems like people are knowing where to go, but they're still feeling like it's hard to access services. About half of folks felt that the behavioral health services meet people where they are in the community. But then we also have about only 37% of folks feeling that housing services are available for those with mental health or substance use challenges. And then only about 26% of folks agreed that community-based services are available for those transitioning out of residential or inpatient treatment. But also just want to point out that in this one, about 40% of folks also said that they didn't know or weren't sure. Then in this last grouping about service experience findings, so overall the feedback was positive, that most folks really do feel like that services are welcoming, that they're respectful of clients' culture, and most people did feel that that behavioral health services have been improving over the last few years. And so on the next slide, if that graph was too much, this is just kind of an overview of the key takeaways. So just again, kind of in population needs, some mixed findings with people feeling that peer support services are meeting the needs of the community, but maybe feeling less favorably about kind of early intervention services, and kind of mixed feedback about crisis services and services overall. Most people know how to access behavioral health services, but felt it wasn't easy to get an appointment. About half of folks do feel like services meet people where they are in the community. A lot of folks felt that housing services are unavailable for people with behavioral health needs. And then again, kind of the service experience is generally positive, with people feeling that services are welcoming, respectful, and have been improving. And so Paulina, there's going to be more information, kind of more context in the qualitative information. So I'm going to hand that over to Paulina to walk us through the rest of the findings.
Awesome. Thank you, Jamie. All right, so we're going to first talk about housing support needs. So this was talked about in both the focus groups and interviews as well as the survey. So we're putting it together into one slide. So I think we'll start on the right, actually, looking at the graph. So 48 individuals completed the housing question in the survey, and you can see that most people felt support in finding, securing, and helping people live independently. Those were the most important ways in which folks with behavioral health needs, supporting them in obtaining and maintaining housing. In addition, from what we heard in our focus groups and interviews, there are not enough staff to help people find permanent housing. So although that is something that would really help folks in obtaining or maintaining housing, that is a barrier. Community members and providers reported too that there are not enough housing options. So we're going to talk a little bit more about that in the next few slides as well. Furthermore, existing housing options do not offer the types of support people need. For example, families, individuals with pets, and those in recovery. And other barriers to housing include stigma, low housing stock, and affordability. And we're going to be diving into that a little bit more in the next few slides as well. Before we go into gaps and opportunities, we want to take a moment and talk about the strengths of the behavioral health system, because there are a lot, and folks really highlighted really amazing things that are happening within the behavioral health system. So firstly, peer support centers, folks really highlighted these as a system strength. The centers offer accessible, welcoming, and non-clinical mental health support. Folks also noted that they're highly effective in providing resources, encouraging service engagement, aiding recovery, teaching coping and life skills, fostering self-efficiency and self-advocacy, and helping clients maintain mental health stability. And we have a quote that actually speaks to this well, where a focus group participant said, I've struggled with a lot of things, but I have someone to talk to here at a peer support center. And that's really nice. It gives me something to do instead of sitting at home. It's nice to be a part of something. It's nice to use resources here. Next, folks felt that the enrollment process for behavioral health services was really fast and easy. Within Lake County Behavioral Health and the broader behavioral health system, folks also noted that services for children and youth, including counseling, case management, are really effective. These services teach coping skills, they boost parental confidence and well-being, and they aid in system navigation. And the quote on the bottom speaks to this really well, saying, working with behavioral health services has given me confidence. With the support my children receive, I see them improving and doing better, which helps me with my well-being and sense of security. And that was from a focus group participant. Next, going to the bottom row, Lake County provides a variety of services for substance use, addressing needs such as tobacco use, youth substance use, and opioid use. And lastly, the behavioral health system partnerships have really grown and improved in recent years, leading to an increase in referrals. Specifically, mobile crisis and the peer support centers have been really effective in connecting clients to services by leveraging their really strong countywide partnerships. And this is a very high level overview of the strengths. Other services that folks mentioned as really helpful and effective include Parent Partner, Family Stabilization Program, the Lake County Crisis Line, Mobile Crisis, Mental Health First Aid, and Lake Link. So we couldn't put everything on the screen, but there were a lot of strengths shared. All right, so now we're going to talk a little bit about gaps and persistent needs. Firstly, inconsistent referral practices. So although on the previous slide, we shared that there have been substantial improvements in that initial enrollment process for services within Lake County Behavioral Health, there are ongoing challenges with referrals. Some of this is attributed to privacy or data sharing restrictions. However, participants highlighted the need for more consistent follow-ups after a referral is made, and ensuring that a referred individual is connected to services. Next, limited shelter and interim housing capacity. So we touched on this a little bit a couple slides ago, but community members consistently express the need for more shelter beds more generally, and for there to be shelters that meet a variety of different needs, such as family shelters, shelters for individuals living with serious mental illness or substance use, as well as shelters for those with animal companions. Some also felt that eligibility requirements present a significant barrier for folks who are trying to be housed. And all of this overlaps with another challenge in Lake County, which is rising rental costs and low housing stock. Next, we heard from folks that workforce shortages and high caseloads are a persistent need. So community members expressed great appreciation for the dedicated staff within Lake County Behavioral Health, but acknowledged that they're working with very high caseloads. And caseloads are the amount of people that folks are working with and serving. Many people expressed a need for more intensive case management or navigation support with obtaining housing and employment. And when there's high caseloads, that can make it a little bit difficult. And you can see that in the quote over to the right. It says, "Staff are committed, but the workload makes it challenging to do everything well." Next, limited services for those with both serious mental illness and substance use, so co-occurring conditions. Lake County does have a very solid network of substance use and recovery services. However, we did hear that it is difficult to find services for individuals with both substance use and serious mental illness, or maybe a lack of programs that are designed or equipped to provide care for both recovery goals. Next, we're in the last row now. There's a lack of in-network providers for private insurance. So we heard that it is very challenging to find providers who accept private insurance in Lake County, making it more difficult to connect with care in an area that may already be short on providers. And lastly, limited, reliable, and affordable transportation. So Lake County has come up with many creative solutions to the limited public transportation, such as mileage reimbursement programs and mobile services programs. However, community members consistently identified limited bus schedules and coverage as a substantial barrier to engaging in services. All right, so to leverage the strengths of the behavioral health system and address the needs and gaps, the following recommendations came up in our conversations with folks. First, improving the referral and care coordination process. Next, expanding housing and homelessness support, improving accessibility and expanding mobile services, expanding access to peer support specialist certification and workforce development services, expanding provider service awareness and community engagement, and prioritizing equity, inclusion, and cultural responsiveness. And we have a couple of quotes here that speak to these. So on the top, we have only have one shelter in our county, 3 shelters technically, but one is more transitional and another is respite. too much criteria at those spots for the vulnerable people in our county, probably speaking to the eligibility criteria. And when staff make referrals, they aren't hearing back or being assured that these people are being picked up and getting the care that they need. So those are what we've heard from focus group participants. All right, lastly, these are populations that folks noted as the most in need or maybe underserved in Lake County. And the order of these is actually not arbitrary or random. This was also a question that was asked in the survey. Folks were asked to identify which populations were underserved or most underserved. And so we actually saw a lot of overlap in the survey, as well as what we heard in the focus groups and interviews. So firstly, older adults. Participants noted that services are disproportionately geared towards youth, leaving a gap for older adults. Additional issues shared include elder abuse, barriers to access for homebound individuals, and the fact that older adults make up a large segment of the county's population. And from the survey, over half of survey respondents actually indicated that older adults were a priority population currently underserved. And we have a quote to the right from a community survey respondent saying, older adults are an invisible population, a hidden population that must be recognized. Next, individuals experiencing homelessness. So participants highlighted several challenges related to homelessness, such as a significant shortage of affordable housing and shelter beds, with a notable gap in services, especially for families who are experiencing homelessness. In addition, participants felt that the existing services for those experiencing homelessness are not always conveniently located where they are, making it a little bit harder to access services. Next, children and youth placed in foster care. So this is the next population identified as underserved or in need of services. Participants felt that children, as one of the most vulnerable populations, would benefit from more services and programs, including focused substance use services for youth. In addition, participants highlighted the need for greater support for children in foster care. Next, the LGBTQ+ community. It was shared that there's a significant need for increased gender-affirming services and providers, as well as more services for people ages 26 and older within the LGBTQ+ community. And also we heard that LGBTQ+ youth are also experiencing bullying and share needing more support in that area. And the quote on the bottom to the right really encapsulates this. When it comes to the LGBTQ+ community, there aren't many services for us who are 26 and older. There is also a lack of gender-affirming therapists in the county. Speaking from personal experience, I agree. It is hard in this county for certain individuals, and that was from our second community meeting in one of our breakout rooms. Next, we have the justice-involved population. So participants noted that there are limited reentry resources available, and returning community members are impacted by gaps in insurance and medication interruption. And lastly, we have communities of color. So Indigenous and Hispanic communities were identified specifically as needing designated cultural spaces, as well as improved cultural responsiveness and more providers who are bilingual. Other groups and communities mentioned that we want to lift up as well. Young parents were lifted up, specifically that housing services are scarce for this group. Men, many folks stating that there is insufficient messaging promoting male mental health, compounded by stigma surrounding mental health issues for men. And lastly, people with disabilities. There's a shortage of suitable housing options that accommodate folks who may have disabilities, and there is a need for more training for staff on working with individuals with disabilities. All right, so that is going to conclude our needs assessment findings. I know that was a lot of information, and I know we've also been together for an hour. So we're actually going to transition into a 5-minute break before we then turn into a conversation around funding shifts. So I think if everyone wants to take about 5 minutes, to stretch their legs, get some water, please feel free, and we'll come back together at 11:05. Thank you. And if you have any questions in the meantime, feel free to throw them in the chat and we can get back to you. All right, see you at 11:05. All right, we're going to come back together in about 60 seconds. So this is a little heads up. If you've walked away from your computer or grabbing something to drink, please make your way back. Thank you. All right, we're going to get started. I also wanted to lift up the conversation that's happening in the chat. Thank you so much to everyone who included questions on the needs assessment findings. If there are any other questions, continue to put those in the chat and our team will respond as they come in. All right. All right, want to make sure, Jamie, are you back from the break?
Yes, sorry. My internet is just being a little unstable, so going off camera when I don't need to.
That is totally okay. I'll just kind of frame this next section. So next we're going to be talking through Lake County Behavioral Health's BHSA proposed funding shifts and updates. So we're going to start off with an overview of BHSA funding and those shifts, and then we'll be transitioning over to Scott presenting on the possible changes and leading the way to a discussion on strategies of, based on these changes, what can we do to continue meeting community needs. So I'm going to pass it over to Jamie to give the background on BHSA funding, and then we will kick it over to Scott.
Thank you. You can go ahead to the next slide. Okay, so I know we've talked a little bit about MHSA to BHSA and what the different categories are, but also want to talk a little bit about, set the context for the funding shifts that we're going to be going through in this next section. So first on the left-hand side, so MHSA, it's the 1% tax. Of that entire kind of MHSA bucket, about 5% goes to the state for oversight, and 95% of that total MHSA bucket goes to counties and is distributed to counties kind of based on county size. Under BHSA, that's going to change a little bit. So the state is going to be taking 10% and 90% of that bucket is going to be going to counties. The state is also taking on a little bit more. They're doing more with prevention efforts as well as kind of workforce education and training. But going back to MHSA, so this first kind of bar chart on the top, so as Paulina was talking about before, there's kind of three major categories. There's the community services and supports, which makes up the bulk of MHSA funding, about 76%. And half of that goes to the full service partnership program. The other half of that goes to any other community services and supports. So in Lake County, that's things like the crisis access continuum. That's things like some of the peer counseling and some of the outreach and engagement. The other big bucket is prevention and early intervention, which makes up about 20% of MHSA funding. Half of that needs to go towards children and youth under the age of 25, and the other half can go to any other prevention and early intervention efforts. And the prevention, the types of like PI programs, so that's like the peer support centers, also some outreach and engagement, things like the parent or like mental health first aid, the prevention mini grants, the suicide prevention, all of those types of programs are under that. And there's also 5% that goes towards innovation, and that's to test out new different approaches. There's also the workforce education and the capital facilities train and technological needs. We're not including that in there because those are relatively smaller funding sources that aren't necessarily required. But so that's the kind of the current state. The bottom bar chart is showing how this is going to shift into BHSA. So right now, the full service partnership under community services and supports includes services for people who are receiving those services, as well as housing for those folks. Under BHSA, there is still this full service partnership bucket, but that can only be used to fund services for folks participating in FSP. Any housing that's being paid for to folks participating in FSP now needs to go under this new category, the housing, which is going to be 30%. This is a new category. So it will take the housing from full service partnership, but then there are also some conditions on this. So half of housing needs to go towards housing services and supports for folks who are chronically homeless. And then the other the other half of that can be used towards kind of any other housing supports. The third bucket is this behavioral health services and supports. And this is kind of where everything else is being funneled into. So any other community services and supports, prevention and early intervention, innovation, and if the county chooses to do any workforce education and training initiatives or the capital facilities and technological needs. That's all now going into this bucket that's 35%. And there are also some mandates of how that money needs to be spent. So of this bucket, half needs to go towards early intervention services. Of the half that needs to go towards early intervention, half of that still needs to go to children and youth under the age of 25. The other half of that can go towards other early intervention. And then the remaining kind of portion of this behavioral health services and supports bucket can go towards other things that would have been funded under community services and supports, other prevention, early intervention, or innovation. So trying to cram a lot of funding into this kind of one smaller bucket. So just wanted to kind of give that context. On the next slide, we can show a little bit more about what this kind of means for Lake and how these things are being shifted around. For folks who are at the second community meeting, this has changed a little bit, and we've always described that this is kind of a proposed funding shift. But what it's looking like right now, so we're showing the two kind of main funding buckets, the community services and supports, the things that are currently funded under that, and also the things that are currently funded under prevention and early intervention. So on this left-hand side, under CSS, like we were saying, in Lake County, that's funding things like FSP, other different types of housing, outreach, and other community services. So moving forward into BHSA, so all of the services, all of the funding for services and supportive services to full service partnership clients will go into that full service partnership bucket. That's kind of the only thing that's really eligible to go into that bucket. Into this 30% housing bucket, the things that are going to be going into that are, like I mentioned, the housing for full service partnership clients. The county has also been using some community services and supports funding for other kind of housing supports for non-FSP clients. That's this general system development housing, also for the housing coordinator, and then other outreach related to housing and homelessness. So like the street outreach program, for example, would go into housing intervention. On the prevention and early intervention side, there is also a housing program, the Family Stabilization and Wellbeing Program. So that is also eligible to be funded under this housing intervention. And within this 30% bucket, up to 7% can be used towards housing-related outreach and engagement. So the county is anticipating taking advantage of that and using that for things like the street outreach and any other housing-related outreach. Then in this last bucket, this is kind of everything else. So kind of any other outreach and engagement that's not related to housing, the other community services and supports, like we said, like the peer counseling services, as well as the crisis access continuum, the peer support centers, and any other prevention and early intervention services. Under BHSA, there's also the eligibility to move up to 7% of funding from one component to another. So to try and kind of bolster this other behavioral health services and supports, the county is also planning on taking advantage of this opportunity to do a 7% transfer from full service partnership into these other behavioral health services and supports. So kind of what that would mean is that the FSP bucket would go down to about 27% and the other behavioral health services and supports would go up to about 42%. So this is kind of what the proposal is, what they're thinking, what this is like potentially going to look like. And then on the next slide, so this is also just kind of a reiteration, but just showing under BHSA, this is kind of a proposal of what the types of programs would be under each bucket. So under full service partnership, this would be the full service partnerships, the child and adult programs, the forensic mental health partnership, the older adult FSP, and then kind of any other operating costs. Under housing interventions, again, it's any housing associated with FSP, including like boarding care, and any operating costs associated with that, any other MHSA housing, this general services development housing, the housing coordinator, family stabilization and well-being, and street outreach. And then under behavioral health services and supports, like I was saying, this is kind of everything else. So the peer support services, the early intervention services program, older adult outreach and prevention, the peer counseling, parent partner support, the other outreach and engagement, postpartum depression and screening, mental health first aid, the prevention mini grants, the suicide prevention projects, and if there's any funding that's going to be going towards the workforce education and training or capital facilities. I'm also realizing that innovation was left off of this, as well as crisis access continuum. So that's kind of the most full bucket that we're looking at. And also just a reminder that there are some designations of how this money needs to be used within this bucket, that half needs to go to early intervention. And of that half of early intervention, half of that needs to go towards children and youth.
Okay. Can you go back to the slide, please? So just want to kind of emphasize a couple things here. This listing right here of the programs that we have is similar to the slide number 12 earlier, where we listed all the different programs and they were categorized under MHSA's buckets of CSS, PEI, and innovation. And so this is essentially a rearrangement of our programs that we have under the current buckets and what is allowed within each of those buckets. One thing I just kind of also want to really kind of emphasize, kind of, because as you're probably starting to suspect, this is kind of an entanglement that we're in. Originally, MHSA also had full service partnerships. That's something that's still carrying forward. And it was also approximately 35% of the funding that we receive. Maybe it's a little bit, might have been closer to 40, but it was right around 35%. And so what BHSA does is essentially still keeps that 35%, but it splits out it splits out this idea of housing interventions. Previously, our housing interventions were primarily paid for within that 35% of FSP. I hope everyone understands what I'm saying right there. Or that 35% in MHSA for FSP also included what we were spending for housing, mostly, a good portion of that. And so what they're essentially saying is take that FSP and split it out into housing, make that 30%, keep the 35% for full service partnerships, and then everything else would fall under BHSS, 35% remaining. Okay, so you can see that creates a little bit of an issue in doing that. So now we go to the next slide. So what this slide shows is our MHSA 24-25 expenses. The reason that's there is because that is the last revenue and expense report we've completed, which was just completed this now. It's the last full year, why it was done that way. And this is the expenses that we had split based on the new categories of BHSA. Does that make sense? So it's like taking that previous slide right there and putting dollar figures to it. And so what we spent on the full service partnership minus the housing interventions, which are two rows below that, is how this is calculated. And it's also compared to what our 26-27 estimated revenue will be for BHSA. The revenue was predicted by the state in determining what they will receive from the 1% tax. And this is Lake County's very small portion of that, $5.9 million. We spent $7 million in that previous year. There was also within that a one-time $1 million spending to bolster our mobile crisis outreach. So, probably closer in actuality to $6 million. So there is some close comparison to actually what, between 5.9 and the 7. Okay, so as you can see right there, full service partnership. We spent 1.3 million in services and salaries for staff, and we are expecting to get 1.9 million. So we're well within that. The housing, we're pretty close to that being the same as well. It's that second one right there, behavioral health services and supports, where it's 3.4 million, almost 3.5 versus 1.7. So this is where we're going to have our biggest issue. This is where we want to get some community feedback. If we can go to the next slide now. So this is a graphic kind of this last slide, but it breaks it down a little bit more, but within the programs that you saw 2 slides ago, how they fit within these 3 major categories of FSP, housing, and behavioral health services and supports. You can see primarily over with the BHSS, you can see that middle section there, crisis access and continuum. So that's basically, like I mentioned, a one-time cost. But you still have an issue with trying to place all of our programming that is not FSP or housing into that 3rd category. Any questions or comments so far? Okay, I thought there'd be more by now. That's interesting.
I guess I have one. Can you hear me?
Okay.
So with the bigger FSP, but can you guys hear me?
Yes.
Oh, sorry. With the bigger FSP budget for services, does that mean more case managers or specialists for the FSP team?
Good question. What it means is, the expenditures were based on FSP, how it used to be. One of the requirements for under BHSA for full service partnerships is to follow evidence-based practices. And we anticipate that by trying to reach fidelity to those practices, that it will probably cost more to do that. For example, one of the components of those evidence-based practices is supportive employment, which we have not done on a large scale before. And so, that's something that will be increasing. There could be some other costs which can be counted under FSP, such as SUDS outreach. And so there is room or things that we have to do that we could fit under FSP.
Thank you.
Looks like we have a question at the Circle of Native Minds.
Hey, Bill. Going to be 35% services for behavioral health services and support. What I'm seeing here, and this is representation of this one.
Can you guys hear her?
It looks like last year for behavioral health services and supports, we got 3,400,000 essentially. And this year, I mean, we're gonna get 1,700,000. So to me, that looks like we have half as much money for peer support centers and older adults. I know that's oversimplification, but does that sort of make sense?
Did you get that?
I think so. I think the question is, we're going to about have half as much money.
Right.
Okay, thank you.
It's not quite half as much money, but it is significantly less. As you can see, 3.4 million, even if you take off $1 million of that we spent on crisis access continuum, that would still be in the neighborhood of $2.5 million versus $2 million that was spent previously in those on that category. Does that make sense?
Yes, thank you.
So essentially, we have to figure out how to fit a bit of a square peg in a round hole to fit all these programs under BHSS.
Well, I would like to add, it's probably more than just that. What this is asking us to do is a total re-envisioning of our BHSA programming. And that's why we showed the video at the beginning, because the Department of Healthcare Services, State of California, has been very clear about what they want behavioral health plans to do, which is serve the most ill, the highest acuity people with behavioral health needs. And so our peer support, well, they're not really in the definition of Medi-Cal peer support. I would say our wellness centers do not really fall within a clean definition of a BHSA requirement. That is not to say that they have not been a valuable piece of the community. However, the state is moving towards things like the clubhouse model, which requires really dedicated programming and focuses on employment outcomes, for example. And so this is not the same sandbox that we've been playing in. And it was not our choice. It was a voter initiative.
Right. So if we go to the next slide now, if everyone.
I see a hand up at the Big Oak Center.
Oh, okay. Sorry about that. Go ahead. Big Oak.
So my question is, what does that mean for our centers?
Well, it may mean that they change shape. It may mean that they go away. It depends on what the community re-envisions within the guardrails of the current BHSA.
Yeah, if we can go to the next slide, we can talk a little bit about that, because these are some possible strategies to accommodate the funding shifts. So these are some things that the department is considering, and this is what we're seeking public feedback on.
Okay. I speak for everybody here in the Oaks. We need the center here because not all of us can't get to Clear Lake. Not all of us can get to Lakeport. Same with Lakeport people. Same with Clear Lake people. Like, we don't have the means. Not even taking the bus, we don't have the means half the time. And a lot of us can't take the bus because some of us have fears of taking, being in vehicles and stuff. And I speak in front of everybody here. We need the center here in the Oaks. We really don't want to give it up. And if we could do anything to help that, to help not give it up, to help keep it here, we'll do it.
I appreciate that. I recognize that wellness centers serve a critical aspect of the community. I also must clearly state that the general provision of wellness centers does not fall under the obligations nor funding eligibility of much of the BHSA. And so it is likely that when, if, how we engage in this process and things change, they have to provide these evidence-based practices and services. And those tend to be hard to lift. And they're expensive. And again, transitioning from general community wellness to more clinical models is what the state is asking of us. Kim, I see your question in the chat. Yes, so it's absolutely true that this will result, this community planning process will result in some recommendations about programs to move forward in the new BHSA. And we will go out to bid for programs and services as we always do that we don't have the ability to cover ourselves with county staff. And so hopefully that's forthcoming by the end of March. And our current contracted providers for BHSA services will be notified whether or not those programs will change, be eliminated, or go out to a new program, a bid for services.
Well, one more thing, can we actually get protest? Like, can we like do a protest or something? I mean, we could do
At
more than
Sacramento, they passed the law. Go read Prop 1. I mean, I hate to be like that, but it's a law that was passed. Ironically, it didn't pass in Lake County, but the Behavioral Health Services Act Proposition 1 determines what we get to do. So you can certainly feel upset about it. You can certainly write Sacramento, but these were not choices made locally.
I understand that, and yeah, I probably will be right in Sacramento.
Yeah, it's you know, unfortunately, it's just the capacity, the fiscal capacity that we're presented with. We have to meet the regulations of what can be funded and what is not allowed, or just what is beyond our capacity to fund. Denise, you have your hand up.
Yeah, I want to thank you guys for all your hard work you do. I'm just wondering if somebody can just like kind of define, it says here, convert peer support centers to clubhouse model. What does a clubhouse model look like to you?
Good question.
Yeah, so I would actually direct a link in the chat for you to read independently about that. Okay. I don't want to divert this into a specific discussion just on that. But I would encourage everybody to read up on behavioral health transformation, Prop 1, what these evidence-based practices are. The clubhouse model is it's an evidence-based practice. It focuses again on employment. So if somebody, Scott, if you could put up some FAQ on the clubhouse and also maybe all of the other evidence-based practices that we're required to have.
Thank you. I just want to say sometimes it's really hard, change is hard, but however, if it's evidence-based, then probably will benefit.
I think, essentially the clubhouse model, just for people's, brief overview, is a lot of the same things that the Big Oak Center does, with some additions as well, including, as Elise mentioned, supportive employment. So, it's actually the clubhouse model. If we can do it right, and that's the big challenge because we haven't done it before. If we can do it right, could be a big benefit for our community. But it's something that we haven't done before. Yes, we can bill for clubhouse services, but we've never done that before. We don't know what the revenue from that will be. We don't, it's not something that we can depend on because we've never done it before. It is something that we want to explore and see if we can make it work here in Lake County. But at this time, we just can't, plan that it's going to be successful and we're going to be able to bill from it and gain revenue from it and be able to, have all the services that we've done previously plus some. So we're cautious about what we do. I see it as a hope for something that could be a possibility for us, but it's something we need to pilot and master first before we can go beyond what we're doing right now. Does that make sense?
I do see that there's a hand up in the circle.
Oh, sorry.
Did you want me to ask for you?
Sure, please.
So one of our peers wants to know when these changes can be expected to happen.
The clubhouse model.
No.
Well, I think just in general, I can give you even a broader answer because this plan goes into effect June or July 1st, 2026. So, the changes that we're talking about will be implemented at that time. We're going to do some preparation beforehand. The idea is that, you know, we will have a draft plan, as Jamie mentioned earlier, by March 30th. That has to be submitted to the state. They have to, you know, approve it first. Within that period, we'll also be putting together some RFPs to put out, so that by the time we do get to July 1st, we will start transitioning over. The other part I want to mention is the second line on this page right here: integration of peers into treatment staff. That's very significant. That's not so much a BHSS thing, but it's more of a mental behavioral health transformation thing. And what that is a requirement that treatment involve peer staff. So the peer staff, which we currently have, many of them will be integrated into our treatment staff to help our clients navigate treatment. It's a big transformation, but it's a big plus as well, because it's finally being recognized the value of peer support. And so we are looking forward to that. Our treatment staff, leadership is already, you know, figuring out how to make this work and how it's going to, you know, benefit our clients, and so it's you know, that's a piece of this. So this happens to coincidentally coincide with what we're looking at with our peer support centers. So I guess one thing I want to emphasize, you know, despite maybe, you know, consolidating our peer support centers, peer support will expand. I guess I could say that, because it will be expanded into our treatment. We might have less physical locations.
Yes, I brought up last time about the situation of how you try to really get out. You've got some wonderful peers, especially here at the one here in Lakeport. But how are you encouraging your people to get this training? You need them certified, because your issue was, you got very excited about, is you got money if you get these people more certified. So what are you doing to encourage this?
Hi, so I would like to clarify, we're not getting money for these people just when they get certified. That makes them eligible to be able to bill Medi-Cal for those services. I don't want to deny, and I give all the props to the staff of the wellness centers. However, it's important to note that the services that they're currently providing are not billable within a Medi-Cal reimbursable framework, and the state of California has been very clear that that is their direction. And so what happens is we do have a lot of staff who are certified. We actually we're one of the first counties to get staff certified through. We have at least 10. Somebody put it in the chat of how many certified peer support staff we have right now. And so what Scott is saying is that we will be working with these existing staff that we have who are highly trained, and essentially elevating them professionally and integrating them into the clinical teams to be those boots on the ground peers providing Medi-Cal reimbursable services.
Right. So, you know, the other thing that we're also looking at, speaking of what, you know, certified peer support, is leveraging BHSA funding as much as we can to match it with federal Medicaid, Medi-Cal, you know, so we can use our funding, because federal funding, you have to, you know, as that video kind of demonstrated at the beginning, you have to have a local match for it. And we do that quite a bit with MHSA, particularly with our FSP program. But there's still room that we can grow with that to be able to use it to gain even further FFP, as it's called. It's the federal portion of funding, and so that can also help us get through get through these changes. And so we're going to be looking at ways of, you know, some of our programming that has this been pure MHSA, and seeing if there's some things that we can do to tweak it so we can get Medi-Cal reimbursement for it. And that'll be including our contracted providers too. I'm going to put that out there. One thing that we'll also be doing, the third line that we're looking at, is being able to this reminds me of two different things. So I'm going to cover both at the same time here. Third line says expansion of street outreach services with Lake County Continuum of Care. So there's two aspects I want to really emphasize with that. One is just what that says is we are receiving some support from the Lake County Housing Continuum of Care to be able to provide street outreach. And so that will enable behavioral health to strengthen the street outreach that we do, going out to the homeless communities, street outreach, and being able to meet with people, help them enroll in services, and meet their needs. So that's a big part of what we want to do, is actually going out even more into the community. This also brings up another super important thing I want to emphasize with everyone here. That's a partnership between behavioral health as the administrative entity and the continuum of care. And that's something that we're looking at trying to do more of. We want to do more community partnerships. We're looking at what community assistance is out there that can help us address behavioral health within the community. Doing street outreach is one way to do that with the continuum of care, partnering with them. I'm also interested from this group here, if you know of any other partnerships that we could develop, and this is the last line that explores this more, explore partnerships with other Lake County agencies or organizations to help fund some services. So looking at what else, you know, who else can we partner with that we can, you know, achieve the things that our community needs assessment discovered, that other community agencies and organizations could help with. So please be thinking of that. You know, what are some other partnerships that we can build to be able to really meet the needs of our community, the behavioral health needs.
Thank you, Scott.
You bet. I'm sorry, I haven't been reading the chat. I hope
No,
that's
I
being
don't think
addressed.
Yes, it looks like we're having really good conversation in the chat about peers. Carrie confirmed that there's 12 to 15 certified peer support specialists department-wide. And then Wendy also noted that some peers also have further or extended peer certifications. And Elise confirming peers are not going anywhere. So just some really good conversations. I see a lot of heart emojis as well. All right. Awesome. Well, I am going to move us forward into our group discussion. We only have about 10 to 12 minutes for this discussion, so we'll get it started. But there's a lot of ways that you can provide feedback in your voice and your ideas as well outside of this meeting. Feel free, if we're not able to get to your comment today, you can absolutely email it to Scott Abbott, and we'll share his email at the end, as well as directly messaging us as well. So I apologize that we don't have as much time today for the discussion as we had anticipated, but I think we've had really great questions, and I'm glad we were able to go through those. So to kick off this discussion, what we want to hear today is based on the needs assessment findings and the funding shifts, the possible funding shifts that Scott just walked through, what actions, programs, or services should be prioritized over the next 3 years? And with that, outside of Lake County Behavioral Health, what can other community partners, organizations, and providers do to improve behavioral health outcomes? Because as Scott mentioned, not all of this falls within behavioral health, and there are many partners within the county that can assist with addressing behavioral health needs. So this is an open discussion. Feel free to raise your hand if you have anything to add to either of these questions. And yeah, we would love to hear from anyone. I know we talked a lot about peers. Are there other types of programs and services that should be prioritized? I also want to lift up what Carrie said in the chat. A peer at the center mentioned needing to have more access to transportation to access services that are currently provided at the centers. Thank you. Absolutely. That came up in our needs assessment findings a lot.
Yeah.
So we just had a good suggestion here at the circle. You know, peers, and I think that this is where the clubhouse model will come in handy. But having peers do like work for the services, you know, like so at the center, you know, like people would be assigned trash duty, or you know, hey, do you mind vacuuming, or you know, so like instilling those work values and responsibilities, ethical work practices, you know, while they're at the center. So did that grasp the gist of it? Yeah.
And then would there still be like money for meals or food?
Yeah.
It's actually part of the clubhouse model.
It is. Is it more money than what?
No, we had the same, we'll have the same amount of money.
Oh, but if Parks and Recreation hired our people on to work at the parks, and they work at the parks and they clean the parks up after events, and then X amount of money will go to the worker, but the other X amount of money goes towards the clubhouse or towards some kind of you know, service.
That's a good idea.
Yeah, I think you remember one of the key components of the clubhouse model, which we're going to be, like I mentioned, heavily exploring, is in support of employment services, which is something, you know, we haven't been able to do at our centers. And so that's going to, you know, as supportive employment, the kind of things that you are talking about right there are the kind of things that are directly addressed within the clubhouse model of helping people become employed and be able to live independently.
Thank you. There is a chat from Kimberly. Not to open a can of worms, from a fiscal perspective, the proposed approved salary increases for county employees is concerning as it directly impacts program budgets, staffing costs. Maybe it is in the stakeholders' best interest for the county to seek contractors to continue these services as well, as we have more control over employee salaries. Just wanted to raise that up.
That's a careful calculus that every county behavioral health plan must do to determine. It's a variety of factors that drive whether or not you staff a program internally with county staff or whether or not you go out to bid for it. You're certainly right that the increases year after year to bring us up to a competitive advantage with our other counties, comparison counties, has been multi-millions of dollars. It's been a significant driver of our budget and some of our budgetary challenges, as some of you may be aware. So yes, absolutely. That does come into play along with a variety of other factors.
Thank you, Elise. Well said.
Great, thank you, Elise and Kimberly. Does anyone else have anything to add to these discussion questions? And I see the circle has their hand up. Feel free to come off mute.
So what about having some kind of internships? Because I've run across personally here, you've got some very adequate people and your clients and, you know, try to supervise them, but have them be more responsible and maybe have it as an internship, you know, and they can get credit or something.
Thank you. No, that was mine. Thank you.
Thank you.
Was the comment about internships? Sorry.
Nope.
Oh, Janet was saying, and I think it kind of goes with like our 900-hour positions, but internships for some of the peers at the centers to,
Yes,
you know, develop those skills.
Hours. I also want to point out to this group that last year we grew our Medi-Cal billable services by 66%. And that was primarily because we have developed a strong workforce pipeline of internships into licensed professionals of the healing arts, because we offer as part through MHSA clinical supervision to our therapists and whatnot. So that has been a success story.
Yeah, it's you know, one of the key things that we always are trying to do is grow from within. We strongly believe in career ladders. We strongly believe in peer support and peers throughout our organization. You know, there's nothing that's better than having someone who's been in recovery rising through our ranks from experience and education, and, you know, gaining a foothold and a strength within our organization and within their professional life. So that's
not
all.
to belabor it, but just as an added note, we actually have multiple members of leadership who were recipients of our services. So we have peers from top to bottom.
In fact, we probably Elise won't say this, but I'll say it. Lake County is so recognized for that. We've been asked to do presentations across the state, showing off our ability to do that.
Amazing. Thank you, Elise and Scott. I think we have time for one, maybe two more comments, if anyone would like to chime in. This is great discussion on strategies, ideas. I love it. Want to keep it going. Okay. I don't see anything in the chat and no hands are raised. We may.
Sorry.
Oh, no, go ahead.
So sorry, I slipped on that. I think I was just a little confused too. So it was mentioning that like peer support centers is going to go out to RFP. Was that correct?
Yeah, everything that we do will be going out to RFP.
I would say we don't know.
I mean, everything that we
programs are going to go out to RFP. I wouldn't even say peer support centers. We have to take this back and then figure out, based on the calculus I was describing, what programs we will have, whether what it looks like.
Okay, that.
But what I meant is, you know, our current contracts for MHSA are ending June 30th of this year, and so you know, a new RFP process will have to be done for anything that we do.
We're in a meeting right now.
Sure. I guess,
So,
you know what, I can explore this separately too. Can I just appreciate the openness for hearing
these gripes and griefs and concerns and worries, and understand that it feels like you're being as transparent as possible, and just understanding from our perspective, it's just a hard place to sit in because June is like tomorrow. So, it can feel scary for those of us who were kind of waiting in the wind.
Amy, you do such a great job. RCS is a great partner. We're blessed that we have great partners that we already work with in the community. There's some outstanding folks that we deal with. From an MHSA perspective, I just heavily compliment RCS and Motherwise and Canuck Senior Support, and there's so many fine folks that are doing really valuable work in our community.
Thank you so much. We appreciate that partnership too.
And we just want to build on those partnerships, because we realize, with our limitations, we can't do it all by ourselves. We never could. But with these limitations that we have, we just want to look to our community to help our community.
It takes a village. Thank you all so much.
Thank you. I see Denise has her hand up. We do have 3 minutes left, so this will be our last question, then we'll close out.
This is really quick. So I'm wondering, when I went to the site on the clubhouses, I was seeing that there are clubhouses that sometime in May they're going to have open houses. What are the chances that those of us that work in outreach and prevention and in the peer centers could maybe take a trip and just tour one of these clubhouses to, get a firsthand perspective on how they work?
Yeah, I'm sure, as we are developing a clubhouse model, that we will be incorporating, things like that. We're already receiving some training on clubhouse models that the state has been able to contract for us to have. And so we're just, kind of in the beginning stages of that. And so as the further we go along in that training and that technical assistance that they're providing us, in fact, the state, just for everyone's information, with all these evidence-based practices that we are required to implement, the state is providing training. So it's not the blind leading the blind. We're going to get some assistance in all these areas, which is great. This is a major transformation. BHSA is one aspect of behavioral health transformation, and evidence-based practices are a key component to behavioral health transformation. Clubhouse model is but one of those. Our full service partnership requires at least two more. One's assertive community treatment and forensic assertive community treatment. And so, those are some key components which we are also receiving training on. So personally, I think evidence-based practices strengthen our organization. And so I think that, at least I'm counting on that the result of this transformation is that we'll be able to better be providers for our community. And that our folks that we are assisting, it will assist their recovery. And that's always the goal.
Thank you, Scott, and thank you, Denise, for that question. All right, I know that I want to recognize it's 12. If folks need to leave, that is okay. We're going to just wrap up, hopefully in the next 2 minutes. The slides are available to you on the Lake County Behavioral Health BHSA webpage, so we highly recommend taking a look at those and these next steps. But also wanting to plug our meeting feedback survey. So if you had a comment today that you were able to ask or provide, or if something comes up later on in the day, as that always happens to me when after the meeting, I'm like, I should have said that. You can also put your feedback in this form, along with emailing Scott or any other way that is most, that works best for you. So feel free to scan the QR code, and the link will also be put in the chat as well. All right, and to close us out, I'm going to pass it back to Scott and Elise to close us out. And thank you all. So I'll pass it back to you, Scott.
I just want to, again, thank everyone for being here. I can't tell you how much it touches my heart to see you all here and that you have taken the time to attend our community meeting here. I know, your time is very, very valuable. We recognize that, and, but just knowing that you're concerned for the community, for behavioral health is very, very touching. And we take the feedback which you provide very, very seriously. It's one of the things I love about MHSA and now BHSA. It's a grassroots effort, in its formation. At least MHSA was, and the idea was community involvement, transparency, and so I'm just really glad that you're able to participate in that and help us. Extremely, extremely valuable. We love you guys. And Elise, you want to add any more?
I think
Well,
Elise may have had to jump
Okay.
off.
Okay, sorry, I didn't know that.
No, that was wonderful, Scott. And from the RDA team, we echo that. Thank you so much for everyone who took the time to be here today to share their voice. I know this is a long meeting, and I know a lot of hard decisions are happening, but we really appreciate you all being here. If you need anything, our emails are on the screen. Feel free to email us if anything comes up. And we will see you all at the public hearing, hopefully in the next couple of months. So have a wonderful day.